when you use the lowest effective drug dose instead of the highest, we minimize that. And that's very important because some people go to unreputable doctors, or their doctors are just not educated. They escalate the dose very quickly, and that will lead to more side effects.
Thank you.
Go ahead. I'll just add what's really cool about medicine now that we hadn't seen before is that there's so much more information available. There's AI that can help, guide a lot of the care. And I say all that because genetics for people who respond to GLP-1s have actually been discovered. Now, genes, we say load the gun, environment pulls the trigger. So you may have genetics for something, but doesn't mean that the epigenetics, what comes out of it, the phenotype actually comes out. So we do have genes to maybe predict what would work and what would not work, which I find really interesting. And from a population health standpoint, we're gonna learn so much more just given the amount of information that we have now. It's no longer trial and error as much, but we're gonna learn a ton. There's a lot out there. She had one question, the one with the microphone.
Yeah, two things you mentioned, Dr. Diane has, about the GLP-1. One was when the people gained weight afterward when they use it too quickly, that they usually gain more, if I understood well, more fat mass than muscle mass. So how could we prevent that, or if that's something that just happens? And number two, you mentioned something about slowing down the progression of metastasized cancer with GLP-1. That's very interesting.
Yeah, so that's
very important. Yeah, for me, because I don't know if there is a lot of treatment, or actually if there is any treatment in regards to metastasized cancer currently. Like right now, it's more like a deadly diagnosis.
Yeah, and it's not for all cancers, but a study just came out. I can't think of the journal. I don't remember which journal. It came out about 2 weeks ago. And it was actually, I think it was also in the New York Times. So just, you can look it up. I don't want to misquote it, but definitely in two types of cancers. I think breast.
Oh, that's fantastic.
And maybe, but also remember, breast cancer, a lot of it is related to adiposity or fat mass in general.
Oh, okay.
In the breast. So, there might be correlation, not causation, and we have to look at this in more detail, but it definitely does reduce inflammation in certain pathways, and that's probably the mechanism of just reducing overall body inflammation.
And just to add, there's no magic bullet, so it's in conjunction with, standard treatments too, but it shows that there's some benefit to it.
I know. I'm asking the doctor, I'm a doctor as well. I got it. Thank you, doctor. Thanks.
You can pass it forward, thanks.
What about, you mentioned already AI. Can you elaborate it and give examples?
Absolutely.
Well, maybe if you don't understand me, maybe she can translate to American accent.
I understood fully. All right, so the question is about AI in healthcare, and I'll lean into imaging, okay? There's a lot, and some of the research that I do actually is in layering AI on scans that you or I have already done and find what we call opportunistic findings. So let me give you an example. There's, again, I'm a research affiliate, unpaid, but just so you all know, I do love this kind of research. So one company looks at different CAT scans and chest x-rays, but CAT scans seem to be a little bit better, that you may have had. Maybe you went to an ER for one reason or another. Maybe you just had a CAT scan for like a calcium score to look for plaque in the vessels. Maybe you had a CAT scan for lung cancer. Some people get a low dose CT scan. The question is, how do we find out more information? And so one of the things that we're doing is layering AI on top of it. It's a lot of work to actually look at what models are best. So let me give you an example. We all have fat on our chest, right? When you're looking at plaque in the arteries, right? There's different kinds of plaque in the artery. There's hard plaque. That hard plaque, that's what a calcium score is stiff. It doesn't dislodge and cause heart attacks, but it's old disease. And so when you get a plain calcium score, that's old disease in your vessels. But what if you look at the fat that you already have, which is not as dense, right? and you look for that fat inside the vessels. Suddenly, AI is looking at soft plaque. Soft plaque is dangerous. Soft plaque causes heart attacks and gets dislodged. So, whereas 2 years ago even, or actually this just got FDA approved in the past few months, you could say 6 months ago, you would get a calcium score, a chest CT, maybe you see some plaque in the heart vessels, you're like, okay, we don't know whether or not this is dangerous, it's old disease. Now you can actually layer AI and look at soft plaque that would potentially cause a heart attack. Then you can also look at the liver and look for fatty liver disease, right? Fat in the liver. You can look at the spine and calculate, a bone mineral density, right? Which a lot of women over 65, this is the Medicare guidelines. You're gonna go get a DEXA scan, right, for bone mineral density. Suddenly you can get this opportunistically while leveraging AI. Does that kind of make sense how it works in diagnostics? Cool. Yes, ma'am. Oh, sorry, she has a mic.
Yes, two questions. One is, I guess, for you, Dr. Hess, is when you talk about GLP and you talk about when people come off, it seems like worse. It would seem to me if you don't want to be on for the rest of your life, if you start it the way you explain it, someone will be worse off because you'll have all that fat. Is that correct?
They'll be worse off if they don't change their lifestyle, for sure. We know that you're going to gain weight back once you come off
And
the GLP-1,
why-
and you're going to reverse all of your
And
metabolic.
why is that?
Because it's working to treat what you're genetically predisposed to have, right? So nobody tells you to come off a statin. Nobody tells you to stop your asthma controller
Yeah,
medication.
but if I stop my statin, my cholesterol then, or my bad cholesterol will automatically go back to be worse than when I started. That's the thing.
Not everything is worse. I'm just saying the type of weight that you gain back is mostly fat.
Okay, just the same one. And the other part is for Oren is the way that I see you're head of innovations at Augustin. And I guess they do cardiology, is that correct?
Agustin does.
But you're head of innovations. What are you doing in that?
Yeah, so it's a lot of, the example I use, for example, the calcium score, the namesake is the Agustin score, okay? And so what I'm looking at, and again, this is more of an academic thinking exercise that we have, is helping others figure out how to leverage artificial intelligence in clinical practice, which is what I enjoy to do.
Thank you.
Sure. And I'll add one thing about the GLP-1 question, if I may, Diane. To answer your question, I think what happens is, so what Diane represented is a clinical study and the outcomes. So after 70 months or whatever it is, this is what happens, right? It's pretty objective. People are gaining weight. And I think, to Diane's point, maybe there's an aspect of this medication works. I'm losing weight, and possibly the habits that all of us should be doing, myself included, is maintaining an exercise regimen, maintaining an intake of, a varied diet, as opposed to relying on the medication. So that's probably why that exaggerated response when you stop the medication.
So your behavior has changed.
I wonder if the behavior changes, and it just hasn't been studied, right?
And the long-term effects, how long is really our studies now? That's my concern.
That study, the last study was maybe 72 months, so 5 years.
But do we know what's going to happen in 15 years?
We don't know what's
No,
going to happen.
because the clinical trials were only just started a few
Right,
years
so
back.
that's the issue too.
All right, who else we have about?
The white-
We have a mic right here.
Yeah, quick disclosure, I work in a pharmaceutical company on osteoporosis. I read your papers. So I'm very glad to hear about your discussion using AI to explore additional analysis for DEXA. But the question is, how important do you think it is to have some kind of checklist to make sure that all patients who go on the GLP-1 drugs have a baseline test of DEXA, for example, to make sure it is known what their score is when they begin, and check it a year after to see what their bone health is.
Yeah, so to rephrase that, because that's a great question, is you're starting a medication, there are unintended consequences, like potentially osteoporosis that develops for whatever reason, right? What kind of before and after. I will say it's not necessarily standard to do a DEXA scan before and screen for osteoporosis. I would also say that people who go on a GLP-1 sometimes do eat less and may have a calcium deficiency or nutritional deficiency. We've definitely seen that studied. Much of medicine and healthcare comes down to risk benefits, and I've alluded to that. I think for the right population, the benefits probably far outweigh the risk of osteoporosis, truthfully.
Do you see a trend towards more research and funding going towards preventative care? It seems to me that the insurance companies would do very well if that happened.
I think there are good things and bad things about this administration, but I do think that like Robert F. Kennedy Jr. is very much about preventive health, and he's been trying to push the insurance companies to cover more preventative health. I know that you can disagree about his policies overall, but I do think that there is a shift, there's a change in the air. People want to have a longer, not necessarily a lifespan, but a health span. They want to live healthy for a longer time. And what we're doing now is I always said this to my patients who are kids, I feel like it's SpongeBob. We're just putting a Band-Aid. You know, the water leaks and we put a Band-Aid. And what we do and what Dr. Mechanic does every day is he's trying to prevent his patients from this kind of care, that you're going to prevent it before it happens. I think
so. I'll add this, and by the way, we're at time, so when Sabina says we're off, we gotta go, but until then, we're good? Okay. That's a cutoff. I'd say, despite the efforts that administratively, or HHS is trying to do with be healthy, the presidential fitness challenge is back, for example, I do think that I have to say this from a population health standpoint, there are things that are known to be proven to work,